So we are back on track. So we were discussing about the L kappa, origin of left coronary artery from pulmonary artery, and we said that infantile death occurs in 90% of these cases if there is no collateral circulation. But if there is collateral circulation, they can grow in adult life, but they have ischemic cardiomyopathy, ischemic MR, and arrhythmias. So this is the role of imaging in diagnosing the L kappa. This is a picture of L kappa patient. You can see that the RCA here is huge. It's a big RCA. And these are the collaterals which are supplying the left ventricle. And these are different views. This is volume rendered imaging of the CT scan, in which you can see a huge RCA in L kappa patient, and then it is surgically corrected. So anomalous origin of coronary arteries, left arising from the right or right arising from the left. So we'll be discussing this in today's talk. So the prevalence in population is around 0.2 to 0.3%. So you can have 1 in 500. Anomalous origin of right coronary artery, approximately 3 to 10 times more common than anomalous origin of the left coronary artery from the right. Left coronary artery originating from the right coronary sinus is more strongly associated with sudden cardiac death. Right coronary artery arising from the left coronary sinus, although it is abnormal, but it is not that serious as compared to the left coronary artery arising from the right. So majority of sudden cardiac deaths, they occur during heavy exertion when these arteries are squashed in between the aorta and the pulmonary artery. High quality long-term data are extremely limited on this topic, and most studies are small with a short follow-up. But the outcomes generally, they are good. So if we think that it is a malignant disease, but the course is not that much malignant that we consider that every patient jiski arteries anomalous hai, so it's a bad news for him. Although they are prone to have sudden cardiac death, but we can evaluate these patients on various modalities that how much is the risk of sudden cardiac death in these patients. So majority do not merit surgery. So we should keep that in mind, that if there is abnormal origin of the left coronary artery, every patient should not be referred for surgery. We have some criteria. Observation and medical management is best tool, and with proper counseling of the patient, and surgical intervention in only in few who really merit this. So to understand the abnormal coronary arteries, it is important for us to understand the normal coronary arteries, where do they arise. So if we see this picture, so this is the right coronary sinus, this is left coronary sinus and non-coronary sinus. This potential space we should keep in mind. Whenever we are describing an anomalous coronary artery and its future prognosis, this is the space which we should keep in mind. So if anything is passing through this space, it is a dangerous thing. This space should be vacant. So this is the right coronary cusp, and the right coronary arteries arising from here. This is the left coronary cusp, and the left coronary is arising here. So this is a normal CT angio. This is normal anatomy. So this is abnormal. This is abnormal because the left coronary artery is originating from the right sinus, but it is taking a retroaortic course. So it is coming here and it is turning around the aorta, and then it is supplying the myocardium. But it is not being squashed. It is not present in that potential space which we were discussing. So as long as it is not passing through this, it is a benign condition. So left coronary artery originating retroaortic, it is benign condition. Similarly, if the left coronary artery is passing pre-pulmonically, if this is the pulmonary valve and this is the left coronary artery which is passing in front of the pulmonary valve, so this is a benign condition. because it is not passing between the two great arteries. Similarly, this is a subpulmonic course. इसको अंडरस्टैंड करना थोड़ा सा डिफिकल्ट इसलिए बिकॉज यहाँ से आपको इस आर्टरी को हटाना पड़ता है, विच इज़ द पल्मोनरी आर्टरी. So this is the pulmonary artery, and this is although originating from the abnormal place, but it is passing subpulmonically. So again, it is safe, although abnormal, but it is safe. So this retroaortic is okay, this pre-pulmonic is okay, and this subpulmonic is okay. This is not good. This is that's potential space which I was referring to, and you can see that the right coronary artery is originating from the left sinus, and it is passing through that potential space in which it has a chance of getting squashed. And this is again a left coronary artery originating from the right sinus, and it is a bad news because it is being squashed in between the two arteries. So do we have some inappropriate sinus or high risk anatomy which we can validate in future that patient is prone to have sudden cardiac death? Yes, we have. So if the patients, they are having intra-arterial course, as we discussed, above the pulmonic valve, it is a bad news. Left main arising from the right coronary sinus is worse than the right originating from the left coronary sinus. Then this acute angle takeoff is a bad news. If this angle is acute, they are prone to have sudden cardiac death. Then if they have ovoid segment or slit-like orifice like this, if we compare this with this one short axis view, so this is okay, but this slit-like origin is bad. Then proximal narrowing as compared to the distal narrowing, this is not good because they can have sudden cardiac death. Increased length of that artery which is passing through the great arteries, again this is more prone to cause sudden cardiac death. And if the artery is passing in through the wall of the aorta, it is a bad news. And if you can see the systolic squeeze, it is a bad news. And takeoff above commissures is not good. So how do we proceed in these cases? Clinical correlation is highly recommended. Medical history of ischemic symptoms or pain, this is important. Then syncope or pre-syncope. Family history probably is not very important because it doesn't run in the families. 50% of sudden cardiac deaths, they do not have any antecedent symptoms. Functional testing, as Brigadier Mehdi was just telling and Colonel Noman were telling, they are important. Now this patient had abnormal origin of the right coronary artery from the left, and he had a stress echo, stress ETT. You can see that there was ST elevation during the ETT, and he had this long course which was intra-arterial, and opening up was slit-like, so this patient is more prone to have future events. So these are the guidelines. If we find anomalous origin of coronary arteries, we can divide them in left coronary and the right coronary. On left coronary artery, ischemic symptoms are there, or ischemia during diagnostic testing. Class 1 indication is for surgery. And if there are no symptoms, even the surgery is class 2A. If we go on to the right coronary artery side, again, ischemic symptoms are very important. If there are ischemic symptoms or documented ischemia, surgery is class 1 indication. But if there is no ischemia, but the patient is having ventricular arrhythmias, again, surgery becomes class 2B indication. Can we have invasive testing? Yes, we can, but the problem with IVUS is that it might be difficult to get the arteries engaged. It has got exceptional temporal and spatial resolution, and it can give you a horrible picture of systolic squeeze the IVUS. When you are doing the IVUS, you can see the artery being squeezed between the aorta and the pulmonary artery. So we are planning to have a study in AFIC in which we are trying to enroll about 300 patients, in which we'll see the effects of these abnormal origin of coronary arteries on their MRI. This was a small study which I'm showing you. They found out that the patient who were having abnormal origin of the coronary arteries, they had actually fibrosis in their myocardium. So more fibrosis was seen in right coronary artery patients, or origin of the right coronary artery. So what treatment options do we have? So medical management, beta blockers, आपने heart rate को थोड़ा slow करना है so that it is not squashed in between the aorta and the pulmonary arteries. You will tell them to restrict their exercise, which is very important because competitive sports or things like that, they can potentially lead to sudden cardiac death. Surgery, in which we can do, we have surgical colleagues, Brigadier Vakar Pracha is with us. So we can do de-roofing or translocation. What we do in de-roofing is that this artery is coming from the outside of the aorta, and it can be squashed between these two arteries. So what we do is that we can de-roof this artery, the course of this artery, and it goes from inside and it goes to its normal place. Or we can surgically translocate this abnormal artery from its normal site, please. So to conclude, once diagnosed, evaluate for high risk features. And as Brigadier Mehdi was telling, that we can have stress echoes in these patients, stress thalliums in these patients. So once diagnosed, we should evaluate for high-risk features, which include interarterial codes, abnormal origin of the left coronary artery from the right sinus. Do they have inducible ischemia? Do they have symptoms? Age younger, yes, it is a high risk as compared to the older patients. Competitive sports में participate कर रहा है, तो he is prone to have these sudden cardiac deaths. Some professions like soldiers, they are prone to have more exertions and they can have sudden cardiac death. IVUS MRI features, as I have already mentioned, that we are trying to have a big study in which we will see the results of these anomalous origins on the myocardium and their fibrosis. Then if the patients are having arrhythmias, they are more prone to have sudden cardiac deaths, FFR, OCTs. In all these cases, we should have a multidisciplinary heart team meeting, and it should be a shared decision making. So with that, I conclude my presentation. Thank you very much.